Hello, dear friend. Hello, how are you? How to be successful in private practice management and how to run our medical practice clinic in proper way with the best medicine practice and the evidence-based medicine. So I am Leila Mustafi. I am expert and international trainer in OB/GYN and midwifery, and with more than 15 years experience in training, managing, and counseling in OB/GYN and midwifery. So let's start our today class with our topic today in gynecology about HSV, herpes simplex virus, and we are going to talk about genital herpes. So are you ready for that? Let's go. Thank you so much for your beautiful comment and your suggestion. I love to hear from you. Your suggestion and your comment is so valuable for me. Please, if you like our session, please don't hesitate to like, share, and subscribe to our channel in YouTube, Lillie Excellence Center. I will try to make a short training about obstetric and gynecology clinic. And these sessions, this series is about gynae infection. So follow me. Let's go. I will share my screen with you. Let's go through PowerPoint. Okay. HSV infection, HSV or genital herpes. What is genital herpes? As you know, HSV is a DNA virus. HSV has two subtypes. Herpes simplex virus 1, that we call it HSV1, and HSV2 or genital herpes. What is HSV1 infection? HSV1 infections are traditionally associated with the oral area, causing herpes liability, fever blister, and it makes some gingivitis and keratoconjunctivitis, whereas HSV2 infections occur in the genital area. What is the risk factor? The risk factor caused by the herpes virus, children can get infected from uninfected adults and they can carry through life. HSV1 can spread through kissing, through sharing the utensils with the infected person, sharing cosmetics, and HSV2 can spread through sexual contact with an infected person, and risk factors include HSV1, anyone who comes in contact with an infected person, and in HSV2, these infections are high among sexually active people with unprotected sex with multiple partners, and women are more vulnerable. Even kissing someone who has symptoms of an active herpes virus. Spreading the virus through contact with cold sores on the eyes, secretion on the finger or ulcers, sores, or buttocks and upper thigh. And as you know, having certain other illness that lower immune function, such as HIV and AIDS and autoimmune disorders or hepatitis. Eating a poor diet that causes nutrition deficiency and lowered immunity. Smoking cigarettes, drinking high amount of alcohol, or abusing drugs. So we have 4 designations are given for the genital HSV infection. One is primary, as you see. We have non-primary first episode. We have recurrent and asymptomatic viral shedding. In primary, as you see, maybe you will see such this face with and sometimes with blisters, as you see here. In non-primary first episode, maybe you will see a little like this face, or sometimes the blisters are opening. And in recurrent, you will see any of these faces. Sometimes you have asymptomatic viral shedding, that this is the most contagious phase of this virus, and maybe there is no symptoms and no bluster as well, and sometimes even there is no cold sores. What is primary infection? As you see here, primary infection, the first infection ever with either HSV1 or HSV2. No serum antibody is present when symptoms appear. More severe symptoms than in current disease. And serum antibody may take several weeks to a few months to appear. In non-primary first episode infections, you will see newly acquired infection with HSV1 or HSV2 or an individual previously seropositive to the other viral type. Type-specific antibody to the prior infection is present initially. Main face tensions tend to be milder than those of primary infection. And in recurrent infection, you will see reactivation of genital HSV. The HSV type recovered in lesion is the same type as antibodies in the serum. Infection in which antibody is present when symptoms appear may not be aware of previous episodes, and symptoms are mild and short in duration. As you see here, in asymptomatic viral shedding, it is the shape of the virus. I make it colorful for you here. The virus is detected on skin or mucous membranes by culture or PCR in the absence of lesion. In studies in which samples are obtained daily, 20 to 60% are positive for HSV2. And the duration of shedding can be very brief, 1 day or less. Patients who are HSV2 antibody positive but have never had a recognized genital herpes outbreak shed virus at rates similar to patients with a history of recurrent genital herpes. HSV2 is often transmitted during periods of asymptomatic shedding. And genital herpes and symptoms. As you know, we have different shapes in different symptoms in male and female. So if you want to find the symptoms, it depends to your client, to your patients. It depends to their environment, the level of your immunity, and the phase that they are located in that time. For example, if they are in the first stage, or they are in the acute phase, or in the contagious sign. So check, let's go. As you see, there is a male and female picture here, a single cold sore or a cluster of multiple cold sores that forms on the genital buttocks, upper thigh, or near the groin. Even cold sores that become exposed and painful develop a white coating and burn for a period of time before healing. And as you see pain, we will see here the pain, tenderness, and other symptoms of a rash around the cold sores. Symptoms of a viral infection such as fatigue, aches, or a fever. Plus, in men, sores usually occur on the base of the penis and surrounding area. In women, sores occur on the vulva, vagina, and cervix. The first outbreak, as you see here, I show you the shape of the lesion. In genital herpes sores, the sores usually appear around the genitals, anus, buttocks, hips, or thighs. The first thing you may notice is flu-like symptom. What is that flu-like? Headache, fever, fatigue, swollen lymph node, especially in your groin, and muscle pain. Some people say they feel tingling or an itch around their genital or anus. This can last for up to 24 hours. You may also notice a patch of red, as you see here, red, swollen skin, or around your genitalia, as you see it's around genital or anus. Sometimes this patch develops on the thigh or buttock. If this appears, you may see a small blister form on the patch. The blister break open, leaving painful sores. The sores scrap and completely heal, usually within 2 to 4 weeks. As you see here, I show you the different shape. Most people develop only a few sores, but some people have widespread blisters, as you see here, and sores. During the first outbreak, some people also notice that they have pain or difficulty when urinating. If you touch these sores, immediately wash your hands. This helps to prevent the virus from spreading to other parts of your body. If the virus gets in or near an eye, it can cause serious problem. And in repeat outbreak, how to treat a herpes outbreak. As you see in this picture, I'm showing you anyone can have repeat outbreak, but you are more likely to have them if you are a man, have a weakened immune system, or had a first outbreak that lasts longer than 34 days. How to treat? Use ice pack, try a prescription antiviral medicine, and plus reduce stress to help prevent recurrence. Don't touch or scratch. Try over-the-counter antiviral therapy creams and keep the sores clean. Genital herpes there is some risk factor and causes, as I explained to you before. Oral sex with a partner who has core sores and any form of unprotected sex, having sex with multiple partners, having other illnesses that lower immune infection, and symptoms in female most start with menstrual cycle and cause an outbreak of genital herpes. Also, a person may mistake the symptoms of genital herpes for those of yeast infection or bladder infection. Genital herpes can spread in the following ways. For example, receiving oral sex from a partner with a cold sore, touching a herpes sore, then touching the genitals. A baby can contract genital herpes during birth if the mother has the virus. People can sexually transmit the virus even they have no visible symptoms. It is not possible to contract genital herpes from toilet seats, bedding, swimming pool, or touching other objects. The virus can only spread from human to human contact. And about prenatal transmission for HSV, it has different protocol and guideline for antenatal, intrapartum, postnatal, and prenatal transmission rates. As you see in neonatal HSV infection has a high mortality and morbidity rate in infants. And the way we want to detect it is through HSV culture, zinc smear, and polymerase chain reaction. The recommended dose for antiviral agent for genital herpes infection, as you see, we have different therapy, antivirus, plus everyone are different administration in different phase. For first episode, we are using acyclovir, 400 milligram TID or 200 milligram 5 times per day for 7 days. And the next is valacyclovir, 1000 milligram BID for 7 to 10 days, and famciclovir, 250 milligram TID for 7 days. For recurrent phase or recurrent stage, first we will try for acyclovir, 400 milligram TID for 3 to 5 days, or 100 milligram PO TID for 2 days. If the patient is resistant to acyclovir, we can go for valacyclovir and famciclovir. Valacyclovir can be administered as 500 milligram BID for 3 days, and we can go through famciclovir for 1000 milligram BID. And if you want to continue treatment for daily suppression, for acyclovir is a 400 milligram BID. For valacyclovir is 500 milligram BID or 1000 milligram QID if it's more than 9 recurrences per year. And if none of this works for your clients, you can go for famciclovir is 200 milligram BID. What about recommended dose for a pregnant patient? If she's in first episode of infection in primary phase, the first choice is acyclovir 400 milligram TID for 7 to 10 days. And valacyclovir, it is 1 gram orally BID for 7 to 10 days. In symptomatic recurrent episode, acyclovir is 400 milligram TID for 5 days or 800 milligram orally BID for 5 days. And valacyclovir is 500 milligram orally BID for 3 days or 1 gram orally daily for 5 days. There is daily suppression treatment. Acyclovir 400 milligram orally TID for 36 weeks, estimation of gestational age until delivery. From 36 weeks, you will start till delivery time. And valacyclovir is 500 milligram orally BID. From 36 weeks of pregnancy, you will start till delivery time. For disseminated diseases, for 5 to 10 milligram per kg intravenously every 8 hours for 2 to 7 days, then orally therapy for primary infection to complete to 10 days. A screening method for prevent vertical HSV transmission. First of all, weekly cervical culture starting at 34 weeks. Abundant weekly cervical culture, and in the absence of active lesion or paradermal symptom, vaginal delivery should be allowed. At the time of delivery, consider obtaining a herpes culture from mother or neonate for the benefit of the pediatricians. Herpes culture, when obtained, should be obtained from the cervix and the site of recurrence. If there is an active herpetic lesion, cesarean delivery should be performed, preferably within 4 to 6 hours of membrane rupture. If there is a recent infection near term, check cervical culture every 3 to 5 days. T results are negative. And create a strategy to prevent vertical HSV transmission with antiviral therapy. Antiviral separation for gravidas with first episode infection during pregnancy, and routine antiviral separation for gravidas with a history of genital HSV and identification of seronegative gravidas at risk for primary and non-primary first episode genital HSV infection. Prevent of vertical HSV transmission with cesarean section. And there is some social consideration. What is special consideration? It is one about PPROM and HSV infection and procedures and HSV infection during pregnancy and breastfeeding and HSV infection. Most of you know about PPROM. Most of studies prove that HSV will increase risk of PPROM. And as you know, we have some mothers, they need some need for some procedures during pregnancy, some procedures that they have to go through their abdominal treatment or diagnosis test. So in that cases, it's very important we can find a way that be less harm for our mothers. As you know, sometimes mother need for amniocentesis, or they go for they need some circulate for their cervix during pregnancy. So there is some protocol for that. You have to consider this protocol, which going about talking about how to do in that situation. There is a new guidelines, and it's about transmission of HSV. These guidelines, first of all, about prevention of vertical HSV transmission with cesarean section. In women with HSV isolated from genital secretion and delivery, neonatal herpes occurred in 1.2% of infants delivered by cesarean birth, compared with 7.7% of infants delivered vaginally. Owing to the potential catastrophic nature of the disease, cesarean section is indicated in women with active genital lesion or prodromal symptoms. For women with a primary or non-primary first episode genital HSV infection during the third trimester of pregnancy, cesarean delivery may be offered owing to the possibility of prolonged viral shedding. If a non-genital lesion is present at the time of delivery, a cesarean section is not indicated, as such lesion may be covered with an occlusive dressing. And about PPROM and HSV infection, an increased risk of transmission occurs with rupture of membranes. For pregnant patients with recurrent HSV infection and preterm premature rupture of membranes, the risk associated with prematurity must be balanced with the risk of in utero infection on a case-by-case basis. In women with preterm pre-labor rupture of membranes, there is no consensus on the genital age at which the risk of prematurity outweighs the risk of HSV infection. If delay of delivery is appropriate, IV acyclovir 5 mg per kg every 8 hours is recommended to shorten the duration of active lesion. For pregnant patients with a primary or first episode of genital HSV infection and PPROM, no data are available for the risk of fetal infection for extent management. And about procedures and HSV infection during pregnancy. Transcervical procedures such as circulation replacement should be avoided while an active lesion is present to prevent transmission. Transabdominal procedures such as amniocentesis and preconscious umbilical cord sampling are not contraindicated in women with a history of recurrent HSV infection. These abdominal procedures may even be performed in the presence of an active lesion if necessary. An invasive monitoring such as fetal scalp electrode is a risk factor for transmission and increases the neonatal infection risk by 6-fold. However, if there are indications for the invasive monitoring, it is reasonable to use if no active lesion is present. And about breastfeeding and HSV infection. Breastfeeding is not contraindicated if an active lesion is not present on the breast. While acyclovir appears to be safe for breastfeeding women, although acyclovir was found in the breast milk, its concentration that were higher than in the maternal serum. The amount of acyclovir in the breast milk was only 2% of that used for the therapeutic dose in neonates. So in the conclusion, we reached to that level that in 2020, the American College of Obstetric and Gynecology, ACOG, brought a practice bulletin on HSV in pregnancy that replaced an earlier practice bulletin from 2007 that the recommendation is as below. One is first is level B recommendation. First is in pregnancy, suspected genital herpes virus infection should be confirmed with type-specific laboratory testing. However, retesting is not warranted in pregnant women with a history of laboratory confirmed genital HSV infection. Second, women with a clinical history of genital herpes should be offered suppressive viral therapy at or beyond 30 weeks of gestation. For primary outbreak that occur in the third trimester, continuing antiviral therapy until delivery may be considered. Because of enhanced renal clearance, the doses of antiviral medication used for suppressive therapy for recurrent HSV infection pregnancy are higher than the corresponding dose in non-pregnant women. As cesarean delivery is indicated in women with active with genital lesion or prodromal symptoms such as vulvar pain or burning at delivery, because these symptoms may indicate viral shedding. And there is some level C recommendation, that is routine HSV screening of pregnant women is not recommended. In addition, routine antepartum genital HSV culture in asymptomatic patients with recurrent disease are not recommended. In general, cesarean birth is not recommended with women with a history of HSV infection that no active genital lesion or paradermal symptom during labor. However, for women with a primary or non-primary first episode genital HSV infection during the third trimester of pregnancy, cesarean delivery may be offered owing to the possibility of prolonged viral shedding. A cesarean delivery is not recommended for women with non-genital lesion. This lesion may be covered with an occlusive dressing and the patient can give birth vaginally. In women with preterm pre-labor rupture of membranes, there is no consensus on the gestational age at which the risk of prematurity outweighs the risk of HSV when expectant management is elected. Treatment with an antiviral is recommended. And in 2030, AAP, American Academy of Pediatrics, they published one protocol about HSV infection and about AHV algorithm. And let's bring a brief summary about what we talked. And yeah. Yes. Oh, yeah. We talked. So we spoke about how to manage first episode of HIV infection, that was using analgesia, antiviral therapy, superinfection, and counseling patient education. And for recurrent HSV management strategy, the most effective episode treatment is patient initiation of a 5-day course of antiviral therapy upon onset of prodromal symptoms. And it was including famciclovir, acyclovir, valacyclovir, and counseling and patient education. And in pregnancy, we talk completely about all protocols and antiviral regimes for genital herpes and recurrent episodes, how to treat and manage the treatment, and daily suppressive therapy. And now we reach to alternative treatment for genital herpes. As you know, most of you know, we have different alternative CAM, complementary and alternative medicine. One is warm and cold compressing. As you see, we are using different cold compress using ice pack or soft washcloths filled with ice, baking soda paste, crushed garlic cloves mixed with olive oil, and topical apple cider vinegar. So about diet and supplementary for herpes, there is amino acid lysine supplements include vitamin A, E, C, B6, B12, and mineral selenium and zinc, licorice, burdock, and dandelion, and Sibrian ginseng. And we try to counsel patients for avoiding foods that foster acidity, include most highly processed food, coffee, soft drinks, sugar, alcohol, white vinegar, tomato, red meat, fried foods, and white bread. The most diet with suggestion is from fresh whole food, particularly green and yellow vegetable, fruits, legumes, and whole grains, especially millet, yams, green salads, and high-quality protein, such as chicken and fish, promote an alkaline state that discourage growth of herpes virus, plus impact of stress and the immune system. And we have different CAM like coconut oil, molarine, Valtrex, healthy diet, appropriate sleep, finding way to decrease stress in your life. Another alternative for genital herpes like light therapy, as you see here, the laminate thread genital sore treatment device, and Ayurveda treatment. And we have some topical ointment like Femiclear and some skin Vaseline for just making a little softness to the cold sores. We have different treatment in CAM for genital herpes, and they did many studies about effectiveness of them. As you see, the list of different CAM that we use, they studied and they said that no sure results came from all of them. But about efficacy, we were not sure how much they were efficacious. But the only thing is very important about that, there was possible side effect for some of them, as I mentioned here, as that we have to care about these side effects if we use for huge amount and high dose. So I have one case study at the end. I want you guys to read this case study and answer in the comments. Yes, real A 29-year-old female patient went to her doctor complaining of painful blister on her labia. Jill was in a monogamous relationship of 8 years with her husband. However, she admitted that they had recently been separated for a few months, but they were currently back together. Jill was unsure of her husband's sexual practice during their separation. Additionally, her husband did not have any indication of illnesses. Laboratory tests of fluid from the blisters indicated the absence of gram-positive or gram-negative bacteria. This paper discussed the finding of the case study by describing the possible infection, causative organism, epidemiology, and treatment. So I'm waiting to hear from you. Your answer about this case study. Please don't forget to write your answer in the comment below. And please, if you have any compliment, suggestion, and your feedback, don't forget to mention in our comments. Thank you so much to being with us. I hope these short courses be helpful for you and you could reach to some new experience and a scope of practice in your clinic. Thank you so much. Have a nice day and see you.